everyone, I'm Dr. Ashy Suresh. Today we are going to be discussing some previous year questions for your NEET PG from the subject of anesthesia. So let's start with the first question. What is true about the position shown in the image? So as you can see, there's a pillow below the patient's head, and Atlanta occipital junction is extended along with cervical flexion. So this particular position is called as the sniffing the morning air position. So let's go more into it. So what does sniffing the morning air position do? So normally if the patient is lying in a neutral position with head in the neutral position, what happens is that if you look through the mouth, you cannot see either the pharynx or the larynx because those visual axes are not in line. Now, for a successful intubation during direct laryngoscopy, when you look after the direct laryngoscopy, you should be able to see through the mouth, you should be able to see the pharynx and then the larynx. So, the vocal cords in the larynx, as soon as you see that, now you can pass the endotracheal tube directly through the vocal cords. So, how can you make all these axes aligned? Because as you can see in neutral position, all three axes are not aligned. So, first step you do is cause a cervical flexion. So, cervical flexion brings the pharyngeal and laryngeal axes together, and that you can achieve by placing a pillow about 10 centimeter below the patient's head. And now still the oral axis is not aligned, and for that you need to bring extension at the Atlanta occipital junction, and that you get by extending the patient's head backwards. So now this particular position is called as sniffing the morning air position. Sniffing position or sniffing the morning air position, which is the ideal position for direct laryngoscopy and intubation. And in this position, oral axis, pharyngeal axis and laryngeal axis are all in a straight line, aligned. So next question. A patient is given a nicotinic receptor antagonist as muscle relaxant. Which drug is given postoperatively to recover from muscle weakness? So let's see what is the action of nicotinic receptor antagonist. So these are the muscle relaxants, right? Muscle relaxants are divided into depolarizing muscle relaxant and non-depolarizing muscle relaxants. Alright, so depolarizing muscle relaxants include succinylcholine, and which has no reversal. And non-depolarizing muscle relaxants, examples are Vecuronium, Rocuronium, Pancuronium, Atracurium, etc. So these non-depolarizing muscle relaxants act by competitive antagonism. So competitive antagonism means that whichever molecule's concentration is higher at the neuromuscular junction, that molecule binds to the receptor, acetylcholine receptor, right? So which are the molecules in play here? Let's say this is a normal neuromuscular junction, and acetylcholine was binding to the acetylcholine receptor and causing depolarization and muscle contraction. And suddenly now we are giving Vecuronium, which is a non-depolarizing muscle relaxant. So as soon as Vecuronium's concentration increases in the neuromuscular junction, competitive antagonism sets in. Now, Vecuronium displaces acetylcholine from the receptors and Vecuronium binds to receptors. What happens? There is no more depolarization. It has blocked the neuromuscular junction. So, muscles won't contract, and that is muscle relaxation. Now, you want to reverse this. That means that if you want to reverse this, that means you have to increase the acetylcholine in neuromuscular junction. So who helps with that? Here we have acetylcholine esterase. So what is the action of acetylcholine esterase? It basically destroys the acetylcholine in the neuromuscular junction. So if you have a molecule which could inhibit the acetylcholinesterase, then that could help to increase acetylcholinesterase, right? So that molecule, which is the acetylcholinesterase inhibitor, is neostigmine. Neostigmine is an acetylcholine enzyme inhibitor. So this neostigmine is used as the reversal agent, because now when you give neostigmine comes and inhibits acetylcholinesterase. Right. Now what happens? Suddenly acetylcholine is no longer degraded. So acetylcholine increases in the neuromuscular junction, and this increase leads to displacement of vecuronium again from the acetylcholine receptor, and now acetylcholine binds to the acetylcholine receptors, and again it causes depolarization, muscle contraction, and thereby it reverses the neuromuscular blockade. Alright. So the other option, physostigmine, crosses the blood-brain barrier, and carbachol is a cholinomimetic agent, and succinylcholine is a depolarizing muscle relaxant. So the answer is neostigmine. Now let's go to the next question. A patient who is undergoing implant surgery under general anesthesia develops tachycardia. Tachycardia, sudden increase in body temperature and muscle rigidity. So this triad of symptoms under general anesthesia points to an autosomal dominant condition called as malignant hyperthermia. So this is a very high yielding question for your entrance exams as well, has been asked multiple times. Malignant hyperthermia. So the question is, which drug is most likely to cause? The drugs causing malignant hyperthermia are all the inhalation anesthetics such as isoflurane, sevoflurane, halothane, ether, and our culprit IV agent is the muscle relaxant succinylcholine as well. Okay, so in this option, the option is D, halothane. So let's get more into malignant hyperthermia. So malignant hyperthermia is an autosomal dominant disease due to the mutation of type 1 ryanodine receptors in the L-type voltage-gated calcium channels. So what happens because of this drug triggers, there's increased release of calcium from sarcoplasmic reticulum, and the muscles are in a constant state of contraction, which will lead to hypermetabolism, increased temperature, rigidity, and this would eventually lead to acidosis, hyperkalemia, and of course it's a life-threatening condition. Alright, and one other important thing is, in the monitor you will have increased End-Tidal carbon dioxide concentration as well. So that along with temperature and rigidity and tachycardia as well as tachyarrhythmias as well points to malignant hyperthermia. So what is the treatment? So immediately we know that the culprit drugs are the inhaled agents, right? So immediately cut off the inhaled agents, give 100% oxygen, and what is usually done is we change the anesthetic machine, because however much you stop the inhaled agents, the tubings might still be having some of the inhaled agents. So we change the machine if possible, or switch to bag and mask ventilation. Then of course temperature is high, so initiate cooling procedures, and the drug of choice is dandrolene sodium, given at a dose of 2.5 mg per kg and repeated every 10 minutes. And of course other supportive measures should also be given for the patient. Okay. Now, what procedure is being performed in the image shown? So you can see that there is a tourniquet here. Actually, two tourniquets are there, and somebody is giving drugs through hand with a tourniquet. So usually you don't do that. So there's an IV cannula, and the arm looks exsanguinated or pale, right? Like the blood has been drained from it. So the procedure going on is a Bier's block. So what is a Bier block? Bier block, or called as, otherwise known as intravenous regional anesthesia. So what goes on here? So this is a block used for short procedures of say 40 to 60 minutes, and it's a regional block, regional anesthetic technique. So either for upper limb below the elbow and lower limb below the knee. And what you do is, of course, in the arm that you've chosen, first we tie both the proximal and distal tourniquet as shown here, and then we use a S-mark bandage to exsanguinate. That means you squeeze out the blood from it, sanguinate. Then you inflate the proximal tourniquet at a pressures of systolic BP more than 100 millimeter mercury. 100 millimeter mercury above the systolic blood pressure. Okay, and make sure that the radial artery pulsation is gone. So now you know that there's no more blood flow towards the limb. So no blood flow means limb will go to a state of acidosis, right? And now what do you do? Into this IV cannula secured in the dorsum as distal as possible, you inject the local anesthetic. So local anesthetic injected, we can use lidocaine, prelocaine, and most commonly used is lidocaine. Less than 3 mg per kg is the dose, and concentration is 0.5%, not more than this. Lidocaine is introduced. So upper limb usually 40 ml is introduced, and lower limb maximum 100 ml is introduced. Okay, 50 to 100 ml, that to 0.25% for lower limb. So what happens? This lignocaine, first it's inside the intravenous area, and then it diffuses out into the surrounding tissue. And on top of that, because there is no blood flow, there is acidosis in the surrounding tissue, which again enhances the local anesthetic action. Again, this is only for short procedures. Okay. So that is Bier's block, or intravenous regional anesthesia. So other options for axillary nerve block, the picture would be something like this because it's given at the axilla. And then we have the median nerve block. If given at the wrist, it would be between flexor carpi radialis and palmaris longus. And then of course wrist block again would be at the wrist. In the condition shown in the radiograph, which of the following procedures is likely to be the most difficult to perform? So the condition, as you can see, there are no lung markings here, and of course the trachea has been pushed to one side. There is a mediastinal shift. So this is a left-sided pneumothorax with mediastinal shift. So mediastinal shift means here tracheal shift is also seen. The trachea is also shifted because the hyperinflated lungs is pushing the trachea and mediastinum towards the right. So nasogastric tube insertion, it won't be difficult because we are inserting through the mouth and we can see the pharyngeal opening. There won't be any difference. Laryngeal mask airway again is a supraglottic airway device. It stops before the larynx, so again not affected. Indirect laryngoscopy, again done through the mouth, right, oral cavity, again won't be affected because we are looking at the larynx. So because of the tracheal shift, the only procedure that would be affected is tracheostomy. Again, one more problem is the landmarks will also have may also vary because of common other contributing factors, may be subcutaneous edema, and the landmarks such as the cricoid cartilage, the thyroid notch, or the sternal notch. So all these landmarks would have shifted, and these are essential to locate the tracheostomy where should be performed, which is usually performed between the second and third tracheal cartilage. 1 to 2 centimeter below the cricoid. And the incision in emergency is made from cricoid to sternal notch. So all this will be problematic because now the trachea has shifted due to pneumothorax. All right. And this is a tracheostomy tube. So it has 3 parts. So this is the outer cannula or the outer tube. Then you have the inner cannula or the inner tube. And obturator is used for introducing. So I do have 2 tubes. Introduction of tracheostomy tube. And why do you have 2 tubes? Because if the inner cannula gets blocked, then you can remove the inner cannula and patient can breathe through the outer cannula. Of course, there is a cuff to get a seal and the pilot balloon to inflate the cuff. All right. Now, at what pressure does the mark structure popped off valve on the anesthesia circuit open? So, pop off valve or the APL valve opens at 30 to 40 centimeter, approximate centimeter of water pressure. Okay, other options are wrong. And let's see what this circuit is. So you can see a reservoir bag, APL valve, fresh gas flow, and the patient end. So let's draw that. Reservoir bag, fresh gas flow, no corrugated tubes. You cannot see any corrugated tubes, right? And then you have the APL valve and the patient end. So let's try to identify the circuit. So reservoir bag, fresh gas flow, no corrugated tube, APL valve, and the patient end. So this circuit is a water circuit or Mapleson C. Mapleson C circuit. Okay, now let's see how to identify all the other Mapleson circuit from A to F. So first thing you have to look at it is the APL valve. So you see the whether the APL valve is present or not. Yes, no. So if APL valve is not present, it's either E or F. As you can see here, both these have no APL valves. And then you see whether the reservoir bag is present. If reservoir bag is present, you can see F has the reservoir bag. Then that is Mapleson F, which is Jackson-Rees modification of IRSTPs, Jackson-Rees, which is used in children, ventilation in children. And if reservoir bag is not present, that is Mapleson E, which is the IRSTPs, and that is used for weaning from mechanical ventilation. Alright, now let's go to the other limb. So yes, APL valve is present in A, B, C and D. Now you see the relationship between APL valve and the patient end. Right. So as you can see in A, B and C, the APL valve is near the patient end. Whereas in D, APL valve is near the reservoir bag. Right. So if APL valve is near the patient end as in these 3, then it's A, B, C, and if it's near the reservoir bag, then it is D. So that is Mapleson D gone. Now between A, B and C, you see the fresh gas flow. If fresh gas flow is before the reservoir bag, as you can see here, before reservoir bag, then it is Mapleson A, and after the reservoir bag, the fresh gas flow, then it is Mapleson B or C. And the only difference between B and C is that in B it has corrugated tubes and C has no corrugated tubes. So if there are no corrugated tube, that is C. Alright, and one more point, the best circuit for spontaneous ventilation is Mapleson A, because the tidal fresh gas flow needed is equal to minute ventilation, so it is more economical. And the best one for controlled ventilation is Mapleson D, again due to the same point, it's economical because it needs the lowest fresh gas flow equal to 1 to 2 times the minute ventilation, compared to others which are very high fresh gas flow is needed when compared to both these in both the settings. Okay. Now, which of the following agents is most appropriate for reversing the effects of Vecuronium in a patient with normal renal function? So, we have already discussed reversal agent, and our reversal agent was Neostigmine. Right. So, here you can see that choice is not here. Now, the answer here is Sugammadex. Now, Sugammadex is a novel reversal agent. So the action of Neostigmine was inhibiting acetylcholinesterase, right? Whereas Sugammadex act by directly binding and encapsulating the whatever it is, Vecuronium or Rocuronium, the non-depolarizing muscle relaxant. Alright, so how does that happen? And this bound structure undergoes renal excretion. So basically, as you can see, it just binds and prevents the action. So the action is immediate action, which is very important. So suppose you give Rocuronium for intubating the patient and you are not able to intubate the patient, means you can immediately give Sugammadex and reverse the patient. But that is not the case with Neostigmine. Needs the time for the effect of the neuromuscular blocker to wean off. Otherwise, the reversal won't happen with Neostigmine. Whereas Sugammadex, you get immediate reversal. Okay, and dose of Sugammadex is 0.1 to 0.8 mg per kg, and contraindication most commonly seen is hypersensitivity reaction, and of course renal excretion. So those with renal failure use with caution. Now other ones, rivastigmine is used in Alzheimer's disease, and physostigmine crosses blood-brain barrier, not a reversal agent, and succinylcholine is a depolarizing muscle relaxant. Alright, so once again, the two reversal agents for reversal of muscle relaxation are Neostigmine and Sugammadex. Okay, Neostigmine acts by inhibiting acetylcholinesterase. Sugammadex acts by encapsulating the neuromuscular blocking drug. Example, Vecuronium and Rocuronium. Okay, and it has immediate action. So this is a very important section. Alright, now a patient undergoing surgery in the prone position is maintained on mechanical ventilation with positive end expiratory pressure or PEEP. What is the primary significance of using PEEP in this scenario? So we'll come back to the options. So what is actually positive end expiratory pressure? So let's say the patient is expiring, right? So alveoli was this large and patient start expiration. get smaller, smaller, and finally alveoli collapse. So in a patients with already who are already respiratory compromised with their respiration, what happens? So in the next breath, to inflate this collapsed alveoli will require a lot of driving force, right, by the ventilator, as well as if the patient is breathing, patient will also have to have such inspiratory force to open up this collapsed alveoli. So to prevent that effort, respiratory effort, what we do is we give a positive end expiratory pressure. So about 5, if you give, what happens? So at the end of expiration, see the alveoli is going to collapse and suddenly there's a positive pressure coming from the ventilator to the patient, which prevents the alveoli collapsing. Prevents the alveolar collapse. So that the next breath, patient just have to inflate this already a little bit inflated alveoli. So the effort or work of breathing decreases. Work of breathing decreases. Okay. Also, you can see if the alveoli is kept open, that means that there's better oxygenation as well. Oxygenation improves, because if the alveoli undergoes total collapse, then it may not be, some alveoli may not even inflate during the next inspiration, right? That means that the oxygen exchange would be affected. So if you give a PEEP, then it helps to keep the alveoli open, and also because you're giving a positive pressure to the alveoli, it increases the intra-alveolar pressure that would help to clear out fluids inside the alveoli, like in the case of pulmonary edema. Okay, so these are the uses, but one problem is as the intrathoracic pressure is increased, because now you are giving a positive pressure. So we know that the negative intrathoracic pressure helps to bring the venous return back to the heart in the next cycle, right? But since the intrathoracic pressure is increased a bit, what happens at the end of expiration? What happens? There's decreased venous return, because there's a positive pressure when inspiration starts. It's not starting from zero. So there's a decreased venous return and cardiac output may decrease a bit. So it depends as high the peak is, the venous return decreases that much. So they are inversely related. Okay, so let's see. It prevents alveolar collapse and atelectasis of the lung. Yes, that's the answer. The other options: decreases inspiratory pressure. No. Now the inspiratory pressure starts from 5. Right? No. Increases venous return. No. Decreases the venous return because of increased intrathoracic pressure. And reduces carbon dioxide in the alveoli. No. So carbon dioxide is governed by ventilation, which is respiratory rate and tidal volume, whereas oxygenation of the patient in mechanical ventilation is governed by how much oxygen you give, that is fraction of the inspired oxygen, and PEEP. All right. So next question. The airway device shown in the image is nasopharyngeal airway. Which of the following statements regarding this device is true? It can cause damage to teeth. No, you are introducing the nasopharyngeal airway through the nose and it rests in the pharynx. You are bypassing the oral cavity, so no. It can be used in conscious patients. Yes, it compared to oropharyngeal airway versus oropharyngeal airway, the nasopharyngeal airway is better tolerated by conscious patients. That is true. It does not cause laryngospasm. No. Any airway manipulation could trigger laryngospasm. All right. It can be used safely in facial trauma? No. So facial trauma cases might have a hidden basilar skull fracture, and if you introduce an nasopharyngeal airway with the anterior cranial fossa fracture, what happens? It might go to the brain and further cause injury, and also there might be bleeding inside the nose. So if you introduce a nasopharyngeal airway, it might lead to epistasis and uncontrollable bleeding as well. Okay. How do you introduce the nasopharyngeal airway? So the correct method is, of course, perpendicular. The patient is lying down, not parallel to the patient's floor of nose, perpendicular to the patient's airway, in line with the nasal passage, with the bevel of nasal airway. So this bevel, this one facing the septum, nasal septum. All right. How do you size? It's the same size as the nasal tube, or that is nasal ET tube you are planning to introduce, or 0.5 to 1 less than the oral endotracheal tube. All right. And this is the nasal airway in situ, nose, and here you have the tip in the pharynx. Again, it helps to relieve upper airway obstruction. So let's go to the next question. Which of the following statements is true regarding the eutectic mixture of local anesthetics? So eutectic mixture of local anesthetics is a mixture of equal weight of 2.5% lignocaine plus 2.5% prilocaine. So both are local anesthetic agent. So it's a mixture you use to apply on the skin before any procedure to get local anesthesia. Now let's see, why is it called eutectic mixture? So eutectic means the mixture of lignocaine and prilocaine has a lower melting point than that of either lignocaine or prilocaine. So this particular mixture is a liquid at room temperature, as you can see here, the white mixture. All right. Now prilocaine, of course, is notorious for the side effects methemoglobinemia due to, so what happens is that prilocaine has its metabolite, which is O toluidine, oxidizes hemoglobin to methemoglobin, and methemoglobin has a reduced oxygen carrying capacity. All right. And the treatment of methemoglobinemia is methrin blue, and the prilocaine dose for methemoglobinemia is usually when it exceeds more than 600 milligram. All right, so let's see the options. 1 gram of 0.5%, no, actually it's 2.5% lignocaine. So methemoglobinemia is a side effect, yes. It's an equal mixture. No, it's not an equal mixture by action. It's a mixture of 1:1 equal weight only. And it is made up of lignocaine and ropiocaine. No, it's made up of lignocaine and prilocaine. All right. Now, the image provided demonstrates neuromuscular monitoring in a patient following anesthesia. Which nerve is most commonly used for monitoring in this setup? So, neuromuscular monitoring. So, from the image itself, you can see that the electrodes are at the medial end. So, that is the ulnar nerve, which is used for this neuromuscular monitoring. And why ulnar nerve is picked is because it's more superficial and its course is more predictable, and the response as well. Which response are we looking for? The adductor pollicis response, which is thumb adduction. So what happens when you want to monitor neuromuscular blockade? So we know, say the patient is under muscle relaxant because we have given non-depolarizing muscle relaxant agents. Okay, and now with the electrodes, you stimulate the patient, stimulate the ulnar nerve of the patient. And what you expect is, if the neuromuscular blockade is complete, then the you will get a certain response, right? And the response you are looking for is thumb adduction. All right. So let's see what happens. As soon as you give the stimulus, so if you have given, say, non-depolarizing vecuronium, you can see that the first response is higher than the fourth response. You give 4 2-hertz stimuli. Okay, this is a train of 4 response. Train of 4. So you can see that there is a fade in response, right? And this fade phenomenon is seen with non-depolarizing muscle relaxants. Whereas if you have given scoline and you're giving the train of 4 response using this neuromuscular monitoring technique, then you can see that all 4 responses are of equal amplitude, but decrease in amplitude of the responses are seen with scoline, right? No fade. So again in scoline, if it is a phase 1 block, of course there's no fade, whereas scoline phase 2 block of scoline is the same, exhibits the same fade phenomenon as neuromuscular blocking agents. Keep that in mind, phase 2 block. So phase 1 is the normal block that we expect for a normal patient during anesthesia. And the other nerves, median nerve, it's bit the response is a bit more, the quantification is not that good, and it's not as superficial as ulnar nerve. Then we have the radial nerve. Again, the course and responses are not quantifiable as easily as the ulnar nerve, and metacarpal nerve, there's no nerve. Now, a COVID-19 patient admitted to the ICU on mechanical ventilation develops sudden hypoxia. Examination reveals decreased breath sounds on the left side and increased intrathoracic pressure. What is the most likely diagnosis? So as you can see, this is a left pneumothorax. Because there are no lung markings, the trachea has been shifted, right? And important thing is, patient is on mechanical ventilation, and it's a COVID-19 patient who are prone for pneumothorax and sudden desaturation and increased intrathoracic pressure because of the pneumothorax as well. Okay, so all these points to pneumothorax. Now, that's a left pneumothorax. So, let's see, the options are pneumothorax, right-sided pleural effusion, ARDS, and left-sided pneumonia. So, how the X-ray picture of right-sided pleural effusion would be, you will have a homogeneous opacity, and a fluid level as well, fluid level. Whereas ARDS, again in COVID-19 pneumonia, ARDS will have a fully white out lung with non-homogeneous opacity spread all across the lung. So lungs is essentially white in ARDS, respiratory distress syndrome. Okay, and then left-sided pneumonia. If it was pneumonia, you can see that there will be a non-homogeneous opacity, pertaining to a lung segment. You can see the non-homogeneous opacity here. All right. So these are the X-ray other options. So the right option is pneumothorax. Of course, the pointers were sudden desaturation and decreased breath sounds, hyperresonance. And in the ventilator, since this patient is mechanically ventilated, ventilator will show high peak pressures and high P flat or plateau pressures, because now the lung compliance is reduced because of the collapsed lung as well as increased intrathoracic pressure. That means that it's very hard for the ventilator to try and ventilate the patient because there's a lot of positive pressure pushing back on the ventilator. And if the patient had hypotension, that means that may point to a tension pneumothorax. So if it were a tension pneumothorax, the immediate treatment would be a needle thoracostomy at the second intercostal space in the mid-clavicular line, right, above the rib. So that is where you have to introduce a large gauge IV cannula, maybe 16 or 18. And then you have the, if it is not a tension pneumothorax, then you can introduce a intercostal drainage tube, which is introduced in the fifth intercostal space between the antidal and mid-axillary line. Okay, so if the patient had a pneumothorax, it's important that till the patient is on mechanical ventilation, the ICD is also maintained for the patient, because positive pressure ventilation is being given to the patient. And if you close the ICD, there's again chance of the defect in the pleura reopening and leading to another pneumothorax. So you keep the ICD until patient is on mechanical ventilation. All right. A 30-year-old male patient undergoing surgery was intubated by a final year resident. Which of the following is the most reliable method to confirm the correct placement of endotracheal tube? So let's see all these methods. And the answer is End-Tidal carbon dioxide concentration. So let's see the other options. Okay. So how do you confirm the correct placement of endotracheal tube? With EtCO2 or End-Tidal carbon dioxide concentration. That means that you are just measuring the carbon dioxide which the patient is exhaling. So the exhaled carbon dioxide will only be measured if the endotracheal tube is in the trachea. If the tube is in the esophagus, of course, there's no carbon dioxide coming out, right? So if it is a tracheal intubation, you will get 3 consecutive normal capnography waveform. So if you give 3 waveforms, consecutive waveforms, then yes, the tube is in the trachea. But here you see that the carbon dioxide concentration is going to 0 because the tube has been wrongly put into the esophagus. Okay, that is one of the methods. Amongst this, the most accurate. Then you have in the X-ray, you see where the tube is located, right? Tube tip is usually 5 cm above the tracheal carina or the bifurcation. Then in the X-ray, you can see the cuff of the tube and tube placement, etc. Now, the definitive confirmation of endotracheal tube placement is by using a fiber optic bronchoscope. You put the bronchoscope into the tube, see the tracheal carina, and confirm the tube position, right, with indirect bronchoscopy. Okay. Now, so other options were chest rise. Of course, that's also an option, but the best option is chest End-Tidal carbon dioxide concentration. And most reliable is flexible fiber optic bronchoscopy. A patient presents with headache, vomiting, fever, and meningitis is suspected. A lumbar puncture is planned for cerebrospinal fluid analysis. Which of the following is the last structure pierced by the needle? Last structure, see the question, before reaching the lumbar system. So they are basically doing a lumbar puncture, and ligamentum flavum, dura mater, arachnoid membrane, pia mater. So the structures pierced during spinal anesthesia or lumbar puncture, let's see, from skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, dura, arachnoid. And now once you pierce the arachnoid, CSF is in the subarachnoid space. For lumbar puncture, you are testing the CSF. Subarachnoid space has a CSF. So this is a space used for lumbar puncture as well as spinal anesthesia. Alright. Now let's see the other spaces. So as soon as you pierce the ligamentum flavum, you enter the epidural space, where you give the epidural anesthesia, and there's one another space which is the subdural space between the dura and arachnoid. All right. And then finally you have the spinal cord, pia and spinal cord together. All right. So if the question was which is the last structure pierced before for us epidural anesthesia, then the answer is ligamentum flavum. And for spinal anesthesia, the answer is arachnoid membrane. So the answer, last structure pierced for spinal anesthesia is arachnoid membrane, and for epidural is ligamentum flavum. Okay. Now, which of the following investigations provides the most accurate prognostic information for predicting preoperative cardiac complication? So, usually in a patient less than who has a metabolic equivalent less than 4 meds, we advise preoperative cardiac testing. So, 4 metabolic equivalents means that the patient is unable to do moderate strenuous exercises, or maybe climb one flight of stairs. So you ask a patient, can you climb one flight of stairs without stopping and without being breathless? And patient says no. So less than 4 metabolic equivalents. And then you go for perioperative cardiac testing for a prognostic information. And the test which is most commonly used is the dobutamine stress echography, because it has a high positive likelihood ratio as well as high sensitivity and specificity when compared to exercise ECG. Also, it is non-invasive, whereas coronary angiography is the gold standard, but it is an invasive test. So you cannot perform it in all the patients. If you have some problem in any of these tests, then you go for angiography to, either for diagnosing or right away for treatment. So exercise ECG testing is also done, but it is less sensitive. And the problem is patients having less than 4 meds may not be able to get their heart rates up because they may not be able to exercise that much physically. So physical limitation is a problem with exercise ECG testing. And dobutamine stress echo, what you do is you give dobutamine to stress the heart instead of exercise. Dobutamine or dipyridamole, adenosine, all these are given. Pharmacological stress testing, right? All these pharmacological drugs are given. Adenosine is given, and then you look in the echo for, you stress the heart with these drugs, and you look at the echo for wall motion abnormalities, and accordingly you can see whether the patient is at risk for ischemia or the patient is already having ischemic problems and needs intervention or not before the surgery. So the answer is dobutamine stress echography. A 50-year-old patient with a history of hypertension, diabetes presents with the following ECG rhythm. His blood pressure is 90/40, so means low BP or hypotension, and he has a feeble pulse again. So this is an unstable patient. So always you can see, just see the heart rate in this patient. So 300 by 1 large square, 1 2 3 4 5. So 300 by 1 large square, so 300 per minute, or 1500 by again 5 small squares. So that is again 300 per minute is the heart rate of this patient. So that is definitely tachyarrhythmia, unstable tachyarrhythmia, which is narrow complex and with the pulse, right? Although feeble, pulse is present. So immediately you have to do synchronized cardioversion. So what do you synchronize it with? You synchronize with the R waves. All right. So synchronized cardioversion is the answer, which is the DC cardioversion. And one other drug which is used is adenosine as well, only after the synchronized cardioversion. And approximate joules are usually the manufacturer will have specified joules in the machine itself, but for Otherwise, if it is narrow QRS, usually 50 to 100 joules is used, and patient should be sedated before synchronized cardioversion. Irregular, then 120 to 200. Wide and regular 100 joules, and of course wide and irregular means you should immediately go for ACLS algorithm and check the pulse. And if pulse is there also, you should defibrilize, because now we have a wide and irregular QRS, so that DC cardioversion does not help. You should immediately go for defibrillation. So let's look at the adult tachycardia with pulse algorithm. So first, assess the appropriateness of clinical condition, and our heart rate is 300, and we know a patient is hypotensive, right? Hypotensive. And first, of course, IV access, 12 lead ECG, maintain the oxygen, and of course maintain patent airway if necessary. And persistent tachyarrhythmia causing hypotension, yes, our patient is having hypotension. If it is wide QRS, no. Then vagal yes, then you go for synchronized cardioversion, right? Persistent tachyarrhythmia causing hypotension or altered mental status, signs of shock are there, ischemic chest comfort or acute heart failure, then you go for synchronized cardioversion. And of course, if refractory, see an addition of antiarrhythmic drug or such as adenosine, need to increase the energy level for the next cardioversion. Underlying cause also you should find out, an expert consultation. No, if there are no hypothermia, hypotension or other unstable conditions, if the QRS is wide, if it is no, then consider vagal maneuvers, adenosine, beta blockers, and consider expert consultation. Okay, now the other ones, diltiazem is a calcium channel blockers, which is used as a rate control agent. Rate control agent in stable AF and atrial tachyarrhythmias. And ibutilide is also a class 3 antiarrhythmic drug used in atrial tachycardias. Okay, all this cannot be used because patient is having hypotension, and these drugs will further deteriorate the hypotension. So hypotension, unstable tachyarrhythmia, adult, the treatment of choice is DC cardioversion or synchronized cardioversion. All right. Now, a 3-year-old child presents with drowsiness, refusal to feed. On examination, child is due for a state, and ECG shows ventricular fibrillation. So, ventricular fibrillation means it is a rhythm of cardiac arrest, and now you are going for ACLS algorithm because patient is in the hospital. What is the next best step in management of this patient? So let's see, it's a VF, so stat CPR. Is the rhythm shockable? Yes. Which are the shockable rhythms? VF and VT. Unshockable rhythms are asystole and pulseless electrical activity. So shockable rhythm, you give the first shock and immediately resume CPR, not check the rhythm. You give the shock, resume CPR for whole cycle, that is 2 minutes, and then you see whether the rhythm is shockable or not. And along with the second shock, you give epinephrine. In children, the dose of epinephrine is 0.01 mg per kg. And the shock given is, first shock is 2 joules per kg, second shock is 4 joules per kg. And maximum is 10 joules per kg or adult dose. Okay, so along with the second shock, you give epinephrine, and still if the rhythm is shockable, yes, along with the third dose, you give amiodarone or lignocaine, which are the antiarrhythmic agents. Amiodarone is 5 mg per kg bolus, and you can repeat up to a maximum of 3 doses, and lidocaine, initial 1 mg per kg, loading doses only preferred. And then you try to correct the reversible causes, especially in children. Small babies, you look for hypoglycemia, of course hypovolemia, hypoxia, acidosis, hyperkalemia, hypothermia, and the T's are tension pneumothorax, cardiac tamponade, toxins, coronary thrombosis, and pulmonary thrombosis. You correct the causes as well. So let's go back. Immediate synchronized cardioversion. Now, synchronized cardioversion, as we have discussed, is for tachycardia with pulse. Defibrillate, check rhythm. No. As soon as you defibrillate, it had to be followed up by CPR. You have to resume cardiopulmonary resuscitation for 2 minutes and then check rhythm. So the option is C. Stop CPR? No. It's a cardiac arrest. So you have to continue CPR. Now, the image represents a normal capnograph. What is the segment labeled? C, D indicate. Okay, C, D. Let's see a normal capnogram. So this is the segment in question. So normal capnography means we are measuring the partial pressure of carbon dioxide in the exhaled gas, right? So patient is starting expiration, and first is expiration from the dead space, that is the airway, dead space airway, which is not involved in gaseous exchange, so there's no carbon dioxide there, and also the tubings and the sampling line, right? So first the dead space, which has little carbon dioxide, and suddenly there's an upstroke because now carbon dioxide starts coming from the airway and alveoli, and then we reach an alveolar plateau. So this third phase 3 is alveolar plateau. So alveolar plateau means constant PCO2 is coming from the alveoli, right? So there is a plateau, and the End-Tidal, that is at the end of expiration, whatever the value of carbon dioxide is taken as the EtCO2. Okay, End-Tidal carbon dioxide value of that cycle, and then there's a sharp downstroke as the patient starts inspiration. The inspiration, of course, there's no carbon dioxide. Okay, so let's see. So AB patient starts expiration, so that's a dead space. Then BC is both the mixed dead space as well as the carbon dioxide from the airways, and CD, that is our question here, is the alveolar plateau, and DE means the next inspiration has started. So inhalation fresh air is, of course, between D and E because the inhalation has started, and after E also. Exhalation of dead space air is AB, and then mixed is BC, and alveolar gas plateau is, of course, CD. Alright, CD is the alveolar gas and the plateau, alveolar plateau pressure. So that is the answer. A capnography waveform is obtained from an intubated patient undergoing controlled ventilation. Based on the waveform pattern shown, which of the following is the most likely cause? So let's analyze the waveform. While the patient is undergoing expiration, which is the expiration is allowed by the mechanical ventilator expiration, suddenly there's a negative deflection. So that means that the patient is suddenly inspiring herself. Right, patient is inspiring. That is why E2CO2 suddenly falls because of the inspiratory effort. Right, and then it rises again. So the inspiratory effort is not enough, but it is there, and that is due to the spontaneous respiratory efforts by the patient, and this is called as the Curer cleft. Okay, let's see all these other ones in the graph. So this is the Curer cleft, as we have already discussed in phase 3. Then this is a normal mechanical ventilation, which is a square waveform. Then you have bronchospasm, which has a shark fin, like a fin of a shark fin appearance, and partially obstructed ET tube as well. Then you have Curer cleft in spontaneous ventilation during mechanical ventilation, and you see the baseline always starts from 0 because inspired air doesn't have carbon dioxide. But in this patient, you can see the baseline is starting from 5 millimeter mercury. That means that the inspired air has carbon dioxide. So rebreathing, that is called as rebreathing. So baseline is above 0 in rebreathing, and a leaking ET tube, you have short phase 3. And normal spontaneous ventilation, not mechanical ventilation, and the graph would be like this. And cardiogenic oscillations, one of the options, the graph would have a this serrated appearance because of the heart pushing the lungs during inspiration. You have a serrated pattern in the EtCO2, and then you have esophageal intubation where the EtCO2 falls to 0 because the tube is in the esophagus. No more EtCO2 is coming during exhalation to the sampling line. Okay. For which of the following situations is the recovery position shown in the image most appropriate? So recovery position means a position, why do we use it? So let's see the options. Unresponsive patient, pulse and breathing absent. No. If you have an unresponsive patient with pulse and breathing absent, you immediately go for ACLS or BLS protocol and start with CPR at first. Right. So no, that is not, and patient will be supine for CPR. So that's not the answer. Responsive patient, pulse and breathing present. So basically like you and me, responsive, pulse and breathing present, does not need a recovery position because that patient can protect his or her airway because they are responsive. Unresponsive patient, pulse and breathing present. Yes. So in an unresponsive patient with pulse and breathing present, patient is unresponsive means their airway they may not be able to protect the airway, meaning that any fluids or oral secretion may go into the lungs and cause aspiration, which may cause, of course, airway obstruction as well as later lead to aspiration pneumonia. So to prevent these conditions, we put the patient in a recovery position, that is a true lateral position with the head slightly tilted down, you can see, and so that the drainage of fluids are facilitated. And also because this head tilting also helps to open up the airway and relieve any airway obstruction, and make sure that you will be able to turn the patient back if needed. If the patient's condition worsen, like you lose the pulse, then you will be able to turn the patient back, and also you should be able to have good observation and access to the airway of the patient, and it should be a stable position, and no further injury should be done to the patient while you are positioning the patient. Okay. And of course, unresponsive patient with pulse but without breathing means you give head tilt, jaw thrust to relieve the upper airway, right? To relieve the upper airway obstruction. Again, that is in a supine position. So you see the upper airway, whether something is blocking the upper airway, somehow the airway is closed and patient is not getting adequate breath. So basically patient will be in supine position. So the recovery position is for unresponsive patient who cannot maintain the airway but pulse and breathing is present. Now, a patient presents with stridor following prolonged intubation. The endoscopic view shown in the image with staging system is used for this condition. So stridor, as you can see, this is the glottis and there is a subglottic stenosis. That is, below the vocal cords, the trachea has stenosed. So what happens here? So subglottic stenosis in the larynx is graded by Cotton-Meyer classification. Okay, subglottic stenosis is graded by Cotton-Meyer's classification, and the other one, AJCC and TNM, are associated with cancer, American Joint Committee, and Rutkowski classification is classification for juvenile nasopharyngeal angioma. So those are not the options, and let's look at the Cotton-Meyer classification. So prolonged intubation will cause edema, and which will lead to permanent changes if the cuff pressure and the tube is not changed frequently, and that will lead to subglottic stenosis eventually. Cotton-Meyer classification is based on the percentage of airway narrowing as visualized endoscopically, right? You pass the endoscope and you can see if less than 50% obstruction, then it is grade 1, and 51 to 70% obstruction is grade 2. So more than 70%, so to 99% obstruction is grade 3, and no detectable lumen is grade 4. According to the grades, the treatment protocols are taken. So here you can see, of course, definitely more than 70% obstruction, and that is a grade 3 according to Cotton-Meyer classification. Okay. Now, which of the following best describes a patient classified as ASA physical status 3? So, American Society of Anesthesiologists, physical status 3, according to the American Society of Anesthesiologists. So, mild systemic, moderate systemic, severe systemic disease with constant threat to life. So, let's see the ASA physical classification. So, which is like a prognostic classification. You take all the physical diseases and other conditions of the patient and estimate a mortality risk for the patient if the patient undergoes anesthesia. All right. So let's see. ASA1 is a normal healthy patient, non-smoker, but no or minimal alcohol use. All right. That is classified as ASA1, and the estimated mortality risk after anesthesia is very less, 0.1%. Whereas AC2 is a patient with mild systemic illness, also those patients, current smokers, and those who have well controlled diabetes, hypertension. Pregnancy is also ASA2, and social drinkers are also ASA2. These are the important ones. And ASA3 is severe systemic illness. That means that poorly controlled diabetes, hypertension, those with COPD, and those with a history of more than 3 months of myocardial infarction, CVA, TIA, or stents. All right. And then we have patients with severe systemic illness as ASA4. That is a constant threat to life. So that is a recent MI. For example, less than 3 months MI. All right. Then we have ASA5, which is a patient who is not expected to survive without the surgery. So it's a life-saving surgery. So in conditions such as ruptured abdominal aortic aneurysm or intracranial bleed with mass effect. So these are moribund patients who will definitely die without surgery, and the mortality risk is either ways more than 50%. Why is an ASA6 is a brain dead patient for organ donation. Brain dead patient for organ donation. So that we can pre-operatively tell the patients that this is the expected risk because of your conditions. You are classified as ASA3. Say the patient is ASA3. There's a 1 to 4% chance of mortality and high risk because of your so and so conditions. So you can give the patient, and you can understand yourself that okay, this is how this patient should be managed because the risk is high. So let's see ASA3. So ASA1 is normal, ASA2 is mild systemic illness, and ASA3 is severe systemic illness, and ASA4 is systemic illness with the constant threat to life. Okay, the answer is C. Identify the maneuver being performed in the given image. So you can see that somebody is tilting the head and lifting the chin. So it's a head tilt chin lift maneuver which is performed in emergency to open up the upper airway. So any upper airway obstruction due to the tongue blocking the pharynx. So you are trying to move the tongue, pull the tongue away from the pharynx to open up the upper airway. And if you are suspecting a C-spine injury, then only jaw thrust is used, and that is done using both your hands. You have to pull the both angle of mandible forward without any cervical flexion. Okay, in C-spine injury, don't do head tilt. You might worsen the C-spine injury. Now, third option was head tilt, jaw thrust, head extension is normal, head extension doesn't matter, and inline stabilization. So, what is manual inline stabilization or Mills maneuver? So, this is a maneuver performed in suspected C-spine injury for what? To facilitate a direct laryngoscopy. So as we have discussed in one of the earlier questions, the sniffing morning air position is the optimal position for laryngoscopy, right? And that needs cervical flexion as well, cervical flexion and head extension. But in a patient suspected of C-spine injury, you're not supposed to put the patient in sniffing position. So what an assistant does it either from behind or from front. The assistant pushes the occiput of the patient down onto the table or the baseboard and make sure that there is no sniff or no neck extension or cervical flexion happening to the patient, so that the cervical spine is protected while you are doing direct laryngoscopy. Okay. Now, identify the mask shown in the image, commonly used for patients with COVID-19 infection requiring high oxygen delivery. So, this mask which is shown in the image is called a non-rebreathing mask, NRBM. Okay, non-rebreathing mask. So, what is it used for? So, non-rebreathing mask has 3 valves. 1, 2 and 3. All these are one-way valves. So, the oxygen comes from this reservoir bag. Okay. And the oxygen inlet as well. And this one-way valve here prevents any flow of the expired air into the reservoir bag. Okay. So, that is first one-way valve. And the expired air goes through these flap valves outside. So, this prevents any entrainment of outside room air as well. So, only expiration through these valves. And so, there are 1, 2 and 3. 3 one-way valves. And the reservoir ensures the reservoir should always be filled with O2 and ensures that you get an FiO2 of 0.8 to 0.9, that is 90% O2. So, FiO2 of 0.9 to 0.8 at the flow of 10 to 15 liter per minute. So, that is a good FiO2 for patients like in COVID who requires high oxygen concentration, high oxygen requirements. So, this is a non-rebreathing. No rebreathing means none of the air with carbon dioxide, exhaled air is going into the reservoir bag. They go out because of the one-way valve. They go out through the expiratory flap valve. Okay. Now, the other options was, this is the Venturi mask. You can see the Venturi device in place, and according to the color Venturi device used, you will get from 0.24 to 0.6% FiO2. Then you have the simple face mask or the Hudson mask, and this one is a nebulizer. Okay. A young male patient underwent a regional nerve block with 0.25% Bupivacaine for a minor surgical procedure. Shortly after the injection, he became unresponsive with an unrecordable pulse. Which of the following is the best immediate management for this patient? Of course, unrecordable pulse, you immediately initiate BCLS, ACLS protocol. So, you start CPR. That's the first thing. Now, which drug would you give? So, this is probably a case of local anesthetic systemic toxicity. So, what is local anesthetic systemic toxicity? So, that is due to a toxicity due to local anesthetic, and Bupivacaine is one of the culprit agents which usually causes a systemic toxicity. And how do you know? The symptoms would be because of excess amount of local anesthetics in the system, probably due to you accidentally give it intravenously instead of in the regional block. Inadvertently you have injected the local anesthetic into the artery of the patient or vein of the patient, and now the patient is in the local anesthetic is in the systemic circulation, and that will lead to toxicity. The symptoms usually starts with the perioral numbness, tingling, and some excitatory symptoms, and suddenly leads to cardiovascular collapse in the end. All right. So, so both CVS as well as CNS symptoms are there. CNS is a combination of excitatory symptoms at first, such as tingling, twitching, and a tremor. Perioral tingling is one of the most earliest symptoms, and then slowly it will lead to respiratory arrest, depressive symptoms, right? Respiratory depression and respiratory arrest. The CVS, there is cardiovascular collapse. Cardiovascular collapse. Again, that is due to direct action of bupivacaine on the SA node, which causes SA, sinus brady, and sinus arrest, and also inhibition of mitochondrial metabolism has also been one of the factors which leads to last. Of course, other excitatory symptoms such as seizures also manifest. So the drug of choice for last is intralipid, 20% intralipid, and intralipid therapy. So you see what you have to do in you have to stop the injection of local anesthetic and call for support. You start CPR and other advanced cardiac life support, ventilation and seizure control as well. Alert the cardiopulmonary bypass team because the heart may not start with CPR. So you may need to bypass the heart using the heart-lung machine. And so you need to alert the cardiopulmonary bypass team for ECMO. And then here call for help. What happens is lipid emulsion is given in the dose of, if the patient is more than 70 kg, then 100 ml bolus over 2 to 3 minutes. And if it's less than 70 kg, then bolus 1.5 ml per kg over 2 to 3 minutes. Okay. And infuse later at 0.25 ml per kg per minute. Then if the patient is unstable, you have to repeat the bolus twice. Okay. Then you have to give ventilatory support, control seizures, cardiac life support, and of course epinephrine bolus. Try to reduce it less than 1 microgram per kg. And the pharmacological treatment of last, of course, is difficult than other cardiac arrest scenarios. And lipid emulsion, maximum dose of intralipid is should not exceed more than 12 ml per kg. So thank you. That is this session.